Yeah, hi, good evening, everyone. I hope my audio and video is fine. Can you please just give me a quick thumbs up so that we can start? So today was the INI-CET mid-year exam, and a mixed reaction from most of the students. Some are saying it was very, very tough. Some of the students are saying it is lengthy. Some of the students are saying that it is as usual the AIMS pattern with lot of tricky things. The topics were very simple, but the choices were very, very tricky. So according to me, if you ask me, that it's a standard way that the AIMS prepare the pattern over a period of time, and I don't see much of a difference. Just give me a sec. I don't see much of a difference. It was a usual paper, but one thing that before I start talking or discussing about the INI-CET questions related to the radiology, I want to tell you that there is a big difference between the way that the questions are structured in the INI-CET exam and the way that the questions are structured in the NEET exam. So guys, please remember, do not change your preparation pattern on the basis of the way that the question have been asked in today's exam. Okay, so INI-CET is known to prepare the paper in this matter. This is not the way that the NEET questions are being prepared. Expect the same kind of pattern in the paper in the NEET that we are getting for or we got last year also, and similar to that pattern. So please do not get into a panic mode. Do not get into a stress with that. Okay. So now coming on to the questions. As we know that the AIMS asked a question in a very mixed pattern, and though I tried my level best to get the best possible question, but in lot of questions, when I have interacted with 10 students, all the 10 students have given me different answer and the different choices, and sometimes a different question also. Why? Because this is a human brain. We always try to justify the answer that is given by us. If I have marked A answer for a particular question, I try to justify that the answer is A. And when it's an image-based question, the answer is totally dependent on the exact image. So rather than giving you the exact answers, I will try to put forward my perspective, and as well as that what could be the most appropriate answer and what the examiner might have thought while making it. Please feel free to put in the comment section about the if you feel that there were difference in the choices or there are difference in the pattern. Okay, so going with the first question, a 34-year-old woman after road traffic accident landed up in the AIIMS emergency with a GCS of 3. She was intubated and sent for NCCT, which was found to be normal. What is the most likely diagnosis? So I think this is a very standard question. I don't think there is any challenge in this particular question. It was a typical, we always read about a characteristic triad. Triad is road traffic accident, unconscious patient, and a road traffic accident, unconscious patient, always go for NCCT. And if NCCT is normal, think of diffuse axonal injury. It's a standard question. I don't think even a single student has done it wrong. It has to be diffuse axonal injury. There is no controversy in this question, and this was a straightforward answer. Please remember, road traffic accident, unconscious patient, always do an NCCT. Not to diagnose diffuse axonal injury, but to rule out other causes like an EDH, SDH, contusions, etc. If NCCT is normal, think of diffuse axonal injury, and you can write it in the comment section. What will be the investigation of choice in a diffuse axonal injury? What will be the investigation of choice in a diffuse axonal injury? Anybody? Please write in comment. Okay. Yes, MRI. The answer will be MRI. All right. So question number 2. This was again a straightforward question. I don't think there should be much challenge, but obviously the language of the question will change the answer. A patient following pelvic trauma with hip fracture present to the casualty with no blood at the tip of meatus. Urine output was minimal following catheterization. What will you do next? Okay. I am not really sure about the language of this particular question. But I think an RGU was given, and probably the RGU, I do not know what RGU was showing, but if RGU was showing a urethral injury, please remember, if you are suspecting a urethral injury, I mean, that there is some challenge in the language of this particular question. But if you see a pelvic fracture, normally, first of all, catheterization should not be attempted. That's a standard thing that has been taught. So, catheterization should not be attempted because it can convert a potential partial injury to a complete injury. So, I'm not really sure on this. If the question is pointing more towards a urethral injury, then I would like to go with a suprapubic catheterization as the first answer. And if an MCU or an RGU is given, then there are very, very high chances that the examiner is talking about these kind of injuries. However, if it's a direct abdominal injury that is being suspected, then I would go with a laparotomy. But I feel that the way that the question has been structured, there should be some changes in the language. I would appreciate if you can share the exact language, and then we will be able to probably put it in a best possible way. And yes, you are correct. Maybe let me discuss with Dr. Jay and let the surgery faculty answer it in a best possible way. So this question has already been discussed by Dr. Sushil in the orthopedic. So 60-70-year-old patient with pain in the hip. My point is that a lot of students said that only the radiograph of one hip was given, and a lot of students said the pelvic x-ray was given. My suggestion to you is, if a pelvic x-ray was given, you had to pay attention to the sacroiliac joint, and if the sacroiliac joint were not clearly visible, then the examiner is trying to give you a sacroiliitis, and if there is a fusion, it has to be ankylosing spondylitis. If it's a unilateral hip joint involvement, in the old age, you should think about osteoarthritis. Avascular necrosis, this is not a typical history which the examiner is gonna give you. If a complete x-ray was given, then the probably examiner wanted you, and the sacroiliac joint wanted to give you an ankylosing spondylitis. These kind of questions, irrespective what I say, are totally and totally dependent on the exact image that is being given. So it's not specifically possible. I assume that in the old age, 70-year, the possibility of an ankylosing spondylitis will be less likely, and the possibility of osteoarthritis will be more likely. If the examiner wanted you to mark the answer as ankylosing spondylitis, it would have been a young age or a middle age. A 20 to 40-year-old male patient would have been the probable history that should be there. Okay, but yes, again, I would appreciate if you will just allow me or give me some of the choices. So this was a pretty interesting question. A lot of students told me that there were two questions on the barium swallow. First of all, can you please confirm that were there two questions on the barium swallow, or was there only one question? I'm just waiting for the two questions, or there's one question. Now, as far as the other question is concerned, budget, chances of giving TB on an X-ray of the pelvis is extremely unlikely. There are radiological dictums that we have to follow. As a radiologist, just on the basis of an X-ray, making a diagnosis of TB is very difficult. So that is something that should not be given. On an X-ray, either an osteoarthritis will be given or an ankylosing spondylitis will be given. AVN, an extreme AVN can be given, but then there would be a history of fracture which is healed or unhealed, something like this. So it will be either osteoarthritis or an ankylosing spondylitis. With an old age, possibility of osteoarthritis is much more likely. Yeah. Okay, so two questions. So one question was something like this. If this was the exact question, this is a repeat from May 2020 AIIMS exam. A 30-year-old patient with progressive difficulty in swallowing for both solid and liquid for 8 months. Barium swallow was done and shown below. What is the investigation that should be done? So going by the history, going by the diagnosis, it is an achalasia cardia, and the best way to confirm achalasia cardia is, we all know, is upper GI endoscopy and manometry. Look at the manometry at the lower esophageal sphincter, which will confirm the diagnosis of achalasia cardia. Okay, so I don't think there will be any problem in this particular question. As far as this question is concerned, different point were given to me. The one student said that it was the least useful investigation to confirm the diagnosis of the patient with following barium image. And again, the image that was shown was probably an achalasia cardia only. I would appreciate if somebody can confirm this. Second image, okay. If anybody can confirm, because if somebody asks me least useful imaging investigation, so normally what we say in endoscopies are not very useful in diagnosis of motility disorders, and that is an area where manometries or barium swallows are the one that are being used. So again, I'm not really sure about the barium leak in the esophagus. Possibility of giving a barium leak in the esophagus probably is unlikely, because in general barium studies are not to be performed if there is a suspected leak. Iodinated dye or water soluble dyes are the one that are being preferred. Guarding was mentioned. If guarding, why esophageal guarding is a problem with the abdomen, why guarding will be there in an esophageal condition? I am slightly skeptical on this point. If the 24-hour pH monitoring is given, that is something that is done in GERD, GERD, gastroesophageal reflux disease, and again that has nothing to do with probably with achalasia cardia, and that can be the answer. And that is why I am slightly skeptical in giving you the correct answer, because that will increase the anxiety. If it's a wrong question or a wrong recall that I am discussing it with you, then probably it may cause a challenge. And that is why my whole idea was to give you a broad idea about the question. Now, what is the importance of giving you this idea? That the same topic can be repeated in the NEET exam. So you have to be aware of that, that you have to be well versed with this topic. Like, that means you have to know that GERD, achalasia cardia, you have to know the 24-hour pH monitoring is the gold standard for GERD, manometry is the gold standard for achalasia cardia, and that is the purpose of discussing this question with you over here, because INI-CET is done, and it's broadly it's done. Your fate of INI-CET is sealed. Whether you mark A or whether you mark B, it cannot be changed at this stage. So then why we are discussing these questions? The whole idea of discussing this question is not just to tell you so that you can calculate your marks. It is basically to tell you that these are important topics, not just for the INI-CET, for any exam. In the NEET exam, it will be asked in a more straightforward fashion or straightforward pattern, but please make sure that you are aware of the question, of the topic, if you are not aware of. Okay, so that's the broad idea. Okay, all right. So least useful investigation among these options, my answer will be endoscopy. But yes, if 24-hour pH monitoring is given in the choice, obviously there is no doubt about it, that will be the answer. Obviously that will be the answer. Okay. But old patient with epigastric pain and guarding present, so all these favor a perforation, and all these will favor a perforation, and neither the pH monitoring nor the manometry are going to be helpful in those cases. Yeah, this was a pretty interesting question, and I think I was able to recall it pretty correctly. Following blunt trauma to the chest, patient present with the casualty, out of the following radiograph, in which case will you do further evaluation before putting a chest tube in the patient? Okay, so these were the 3 x-rays that were told to me, were given. The first x-ray is broadly a normal x-ray. In the second x-ray, you can see that the herniation of the bowel loops or something, a cystic lucency in the left hemithorax. And the third x-ray is a clear-cut hyperlucency on the right side, devoid of vascular marking and separated from the lung by a visceral pleural line, so which is nothing but a pneumothorax. If you see a pneumothorax with a trachea deviated towards the left side, it's a clear-cut case of tension pneumothorax. No other investigation is needed. Immediately put a chest tube or a needle into the second intercostal space or a fifth intercostal space, whatever you want to do, but no further investigation is needed. In this case, you have to confirm whether this is actually bowel loop or not. You cannot put it, you have to do further investigation. And this x-ray looks broadly normal, and if x-ray is normal, I would like to identify that is there a challenge. So I would like to evaluate it further. It was probably a multiple correct type of question. So if you ask me, 1 and 2 are the 2 radiographs where I would like to evaluate further. I would like to evaluate further before going. Even in the first case, bache, I would like to evaluate further because I don't see a reason of putting a chest tube in the first case as well. So second, definitely I want to evaluate further. In the first, if it's a normal chest x-ray also, why would I like to put a chest tube? I would not like to put a chest tube in a normal chest x-ray. So in the first and the second case, I want to evaluate them further, and only then I want to go forward. Okay. First X-ray, lung full of opacity, and the second collapse with pneumothorax, third bowel loop. So if that is the scenario, bache, then in the first and the second, then only in the second. Again, see, as I told you now, see, this is my biggest point, and I want to tell you, these recalls are not to tell you the answer so that you can calculate your marks. This is not for them. It is basically to tell you that these are the things which are important for future exams also. See, my whole idea of doing a recall paper is not to tell you the correct answer so that you can calculate your marks. It will unnecessarily increase the anxiety. No, the whole idea is we have an exam that is coming up. We have to be prepared. We can utilize our 12-14 days in an easy, in an efficient way with the topic which are commonly asked in the exam. So if the first image was not normal and rather a pleural effusion, if it's a massive pleural effusion, I want to put a chest tube. If it's a bowel loop, I don't want to put a chest tube. I want to evaluate further. If it's a normal chest X-ray, I want to identify and I want to evaluate further. If it's a pneumothorax, I will straight away put a chest tube. Okay, so that is how you will go it forward, and accordingly you will have to select. Okay. But if pleural effusion was given, obviously, then I would not further evaluate and I would immediately put a tube. And this is another case, probably I was able to recall it correctly. A 34-year-old patient with pain in the left flank for the last 1 year, I think it was mentioned, has presented to the OPD. CT scan was done, and on CT scan what do we see is a well-defined large cystic area with multiple cystic lesions within. That's a typical appearance of a hydatid cyst, and a typical appearance of a hydatid cyst. So cyst content will cause hyperinsensitivity with leak. Yes, there are always a very, very high chances of them can cause leak. Biopsy should be done in confirmation before doing nephrectomy. This is 100% wrong. No biopsies or FNAC should be done in these cases because it can convert or it can leak and it can cause anaphylactic reaction. Albendazole can be given and is to be given, yes, and yes, it's a dog tapeworm, yes, it's a tapeworm. Okay, there are multiple hosts of it. Yeah, FNAC and biopsy should be done. That's wrong, bache. It should not be done, and that should be the answer. So please remember, examiners are known. Hydatid cyst is a very, very common topic that is asked in the exam. Please remember that the most common site of hydatid cyst is liver. The second most common site is lung. A very, very interesting point about the lung hydatid is known to calcify in all parts of the body except lung. In the lung, it does not show calcification. So whenever we have got these kind of statements, which are exception, they are always important MCQs. They are always important MCQ. TB is known to show calcification in all parts of the body, but TB, once it involves the urinary bladder become contracted, which is called as, anybody who can tell me what do you call it? Thimble bladder. But this thimble bladder does not show calcification. So these kind of things, it should be on your tips. Most common type of Pott spine, a very straightforward question. It is paradiscal. Paradiscal is it's a factual question. Dr. Sushil has already discussed it in your orthopedic recall, so I don't think I will go into the details of that. I think there was another question on the psoas abscess. So this is a specific pattern of the AIIMS when more than one is asked, and those are the one that really challenge, and it is very, very difficult to recall that only 1, 1 and 2, 2 and 3 what was given. So let's see. Consider the following statement about psoas abscess. So we all know that the psoas abscess goes along the psoas, goes along the iliopsoas tendon and reaches up to the lesser trochanter where the iliopsoas tendon is attached, and it commonly forms a fluctuant swelling, in the thigh region. I just need your confirmation onto the choices so that I can tell you, but I would appreciate, I would not like to comment onto the answer of this till the time I have the exact statements and the exact choices. Fluctuant swelling can be elicited in thigh region. Yes. Now some people say pain during the passive movement, some say pain during the flexion, pain during the extension at the hip joint. So usually there is a pain at the extension of the hip joint, and that is why usually the pain, the primary psoas abscess can occur from occult infection elsewhere. Yes. Cold abscess can be seen with the Pott spine. Yes, cold abscesses can be seen with the Pott spine. So I need to know what is the exact choices that were there, and only then I will be able to give the correct answer for that. There were a lot of questions on the dislocation, and what we used to tell in the class is, please remember APPA and APPA. I think all of you remember shoulder anterior dislocation, elbow posterior dislocation, hip posterior, and knee anterior. Okay, so most common nerve damage in the anterior dislocation of the shoulder, axillary nerve. Again, it's a straightforward question. I don't think that there is a challenge in this. So consider the following statement regarding hip dislocation. Most common is posterior dislocation. Yes. Most common is anterior dislocation. No. Vascular injury is common in the anterior dislocation. Neural injury common in the anterior dislocation. So these are more of the orthopedic stuff. But to the best of my knowledge, I feel that the neurovascular injuries are more common in the anterior dislocation of the shoulder. Anterior dislocation of the hip, because the vessels and the nerve are predominantly anteriorly. So 1, 3, 4 should be the correct answer. But again, a lot of people have told me that there are different choices according to that. But please remember, that means dislocation is an important topic. If you have not covered it well, you have to cover it again. A 27-year-old female comes to the OPD with sudden diminution of the vision in right eye. RAPD was diagnosed. Marcus gun pupil, I think, an ophthalmology, you must have read it. So multiple causes of RAPD, optic neuritis. So basically an optic nerve, and according to me, if you ask me, I would like to go for an MRI examination in this case. So this is a question which most of the students have talked about. A lot of students have talked about this particular question. Ki, sir, kya aa gaya ye? Yeah, so I think more should have been given in this particular case. But if it was a laryngeal cancer, so probably examiner wanted you to see that whether the thyroid cartilage is involved or not, because the moment it is involved and it is causing the erosion of the cortex, it becomes a T3 lesion. And obviously the nodes will be seen as separately enhancing structures over here. If they are, obviously it cannot be a metastatic lesion on a single section. That will not be shown you as a metastatic lesion. So if the nodes were not given, I mean at this stage, so it has to be from T1, T2, T3, the cartilage was involved, then it will be a T3 lesion. But this was a difficult question. According to me, this kind of question you need not to be bothered specifically in the paper like NEET exam. AIIMS is notorious in asking at least few questions, and as long as it's 200 questions, 10 to 15 questions are of this pattern, I am not much worried about it. Obviously, as an examiner, also as a student, as a teacher for postgraduate student also, I also believe that 10 to 15 questions or the 20 questions in the paper should be very difficult. But the rest of the paper, around 170, 160, 170 question, should be the one that can be done by the student who has read the subject well. And it's simple. That is what I believe. So these were the broad questions. If you ask me my take about the exam, I don't think that the paper was very difficult. Definitely not. Obviously, the questions like this were slightly bouncers. But obviously, if you are playing a one-day cricket match, you need to have practiced some of the bouncers. That's absolutely okay. But there were not too many bouncers in the paper. 1 or 2 bouncers in each and subject is acceptable and should be there. But majority of the questions were standard. Yes, there were a few choices which were tricky. Please make sure that whatever topics that have been asked in these exams, you are well versed with them. Take a break for the day. Today, if you're not reading today, that is absolutely okay, but it does not give you a liberty not to read it for tomorrow. We have some days left, around 12-13 days left for the exam. My request to everybody is, please quickly go through all the important stuff, all 19 subjects in the next 12 to 13 days. Stay positive, stay confident. I know that there are period of uncertainties that are going on. It's actually unfortunate the way that the government officials, that the seniors are behaving at this stage. It's actually unfortunate. I did not expect this in this scenario, but still I will say everybody to remain positive, and please keep reading. Please keep reading. Do not waste your time. Do not waste your time and keep reading to the best of your ability. I wish you all the best for the INI-CET result as well as for the future exam. May God bless you all. Thank you very much.